Welcome to Is Your Liver Healthy? I'm your host and Vice President at Global Liver Institute, Jeff McIntyre. Who do you trust? For many of us, that's a pretty tight circle. A partner, family members, well, some family members, your lawyer, your colleagues, your doctor. Now, while not often spoken about, trust is a thing that runs through most of our interactions. We trust that when we put the credit card into the gas pump, it's going to work, that when we put on sunscreen, it's going to help protect us, that when we put our money in the bank, it's going to be safe. These interactions build trust over time as we experience them and as we see others experience them. But when we engage healthcare, the question of trust feels more complex. Perhaps there's a condition we're experiencing that's difficult to translate, has an immediacy in our lives, and something that we may not understand about. Put that into a healthcare setting that is clinical and antiseptic by definition. Sprinkle in some confusing insurance terms, the potential for something painful to happen as a part of the treatment or the lack of treatment, different specialist opinions, drug availability or not, and the ability to trust becomes an unexpected exercise in healthcare management. Now, nowhere is this more prevalent and real than in all things clinical trials. Whether in recruitment, understanding consent and protocols, or engaging clinical trials as healthcare, patients are often called upon to trust a mysterious process with confusing terminology and a history where horrible acts are ingrained more than the successes. On this episode of Is Your Liver Healthy? We examine trust in clinical trials, what it is, how clinical trials get there, and the issues for local communities. Joining us are Dr. Juan Gallegos of the University of Utah and Jonatan Garcia of Velocity Clinical Research in Texas. Let's get started. All right, I'm super pleased to have Dr. Gallegos from the University of Utah and our good friend Jonatan Garcia joining us from Velocity Clinical Research. And we're here to talk about trust. Wow, what an amorphous thing this is to try to wrap our heads around, especially coming from a scientific community where we normally deal with, great clinical outcomes and endpoints, to come back to this issue of trust. But it really affects all facets of liver health. I find that it's at the root of issues around stigma. It's at the root around the relationship between the provider and the patient. And there's a big impact in terms of, clinical trials, in terms of recruitment, retention, about even being involved in them. And we found in this age, unfortunately, we have so much misinformation, so much disinformation, even the use of those words of misinformation is, just a kind of a cute political spin, I think, for it's not true. So how do we understand what trust is and kind of what's happening with trust in health and science, especially liver science today as well? Dr. Gallegos, I'd like to start with you. But what do you see as some of the sources of, we'll say, patient hesitation, to use a different term than trust? And patient hesitation can come from a lot of different areas. But in terms of trust, is there historical precedent? Is this systemic? Kind of people bring their own personal issues? What would you say are sources of this?
Thanks so much, Jeff and Jonatan. Nice to be here in this conversation. That's a good question. I think there's probably several layers of mistrust from our patients. Some of the you mentioned from a historical standpoint, we know that historically certain populations have been disadvantaged from participation in clinical trials. A lot of times, we as researchers in medicine don't have the best track record. Many years ago, we would perform research on our patients or individuals without really even asking for their consent, without getting them involved in how the research was going to be conducted, what the potential risks and benefits were of the interventions we were doing. So I think that is a big source of mistrust from a historical standpoint. I think from a systemic standpoint, we also acknowledge that there are inequities in the way that patients can access care. And we know that not all patients, unfortunately, have the access to the same quality or the same level of care. And typically, from specifically research trial standpoint, most of the research trials are only available in certain cities or in certain institutions. So that limits the availability, especially of patients that might live in more rural areas or distant to a big city, might limit their ability to access clinical trials, for example. And then I think
No, go
from
ahead.
from a personal standpoint, I think patients also might have a misunderstanding of what clinical research is. And we've heard a lot about the influence of pharmaceutical companies and potentially patients thinking, well, this particular researcher, this physician or this provider might be getting kickbacks or being paid to push these investigational products on me. And maybe that
Right.
has another source of mistrust.
Yeah, I've heard that in my own kind of personal experience and talking to people, especially from parts of Appalachia where I grew up. I've gone back to visit home, and people have, when I've asked about clinical trials or something, the response has been, "Why would I let a company experiment on me so they can make money?" Basically, and it really just shows kind of this profound misunderstanding. But it's interesting because there are such systemic things that involve with this. I mean, we look at kind of the treatment of people of color and the systemic racism that tends to come in. And so when you have things that they can fall back on, like the Tuskegee syphilis study back in the day, those are really held up as like, we know we can't trust you. Even what were the gynecology experiments, the Marion Sims ones that were so bad, that create this kind of historical trauma that feeds into the racism as well. Which leads me to the next question, Jonathan. What does this look like? I mean, when you're having the conversations with these communities, how is that? What does the mistrust look like when you're in these conversations?
Yeah. So again, thank you for having me, for the invitation. So yeah, in my world, so I work in Waco, Texas, and perhaps the southern area of our nation. And I think a lot of the mistrust, I think, we mentioned, corruption with money, or the idea that money is playing a factor in it. But also, I think a big part of the conversation now is the government, right? I hear a lot like, well, is the government involved? Is this government funded research? And so I think that that becomes a big topic of conversation here. But then something else that Dr. Gallegos said was that there's a lot of misconception on what clinical research is to begin with. And so I think that's almost an even bigger factor in the conversations that I'm having.
It's one of the things that's occurring to me here is that so often we talk about this in terms of the patients mistrusting things. There's patient mistrust, and all of which is incredibly valid. Do either of you feel like there's any mistrust of providers or researchers with the patients? For instance, I mean, is there something that can, I don't think this is necessarily all the patient's burden, if you will. What are things that might be an example of, for instance, that they don't trust that they're going to stay with the trial, or their suspicion of, doing the medicine or anything like that? Is there anything about it? Does this go both ways, I guess is the question.
I mean, being a clinician and investigator and running some of these trials, I do think sometimes we encounter that. Especially when you talk about early phase trials and people getting paid to be a trial participant, and sometimes the payment can be a very attractive way of supplementing someone's income, unfortunately. So I think that can come into play. Most of the trials that I run in our division are more like phase 2 and phase 3 trials, where we are now seeing patients that actually have the condition that we are treating. So the emphasis there is not much. It's not really on how much money the patient is going to be able to make out of the trial, because the compensation is limited. It's in those cases, I think there's less mistrust, because we have tried to establish these care bonds with our patients and trying to be very open as to what we're searching for in our trial and what the pros and cons are of being enrolled in the trial. So most of the patients that make it through our trials typically do tend to stick with them.
Yeah, good, good. Jonathan, I'm wondering, are there common concerns that patients talk to you about? You know, we've talked about the idea that, you know, people are just in it to make money, and, you know, that there's a lack of awareness about kind of the role of clinical research. Are there things that you see that are common that that reoccur with patients and what they express?
Yeah, so for the most part, the most common phrase that I hear out of people's mouths is, "I don't want to be a guinea pig," right? And so that's a big thing that we run into here. And so just like Dr. Gallegos said, we do late stage trials here, and so we really are looking for patients that more of an extension of care, more patients that could benefit from the trials, and so that's more so how we approach that concern each time when they mention be a guinea pig, I don't want to be in a lab. And so more so the risks involved with a potential experimental medication. They want to
Mhm.
know how many people have taken it, what do we know about it already, what are the risks, am I going to be protected, are you going to protect me if something, if this medication ends up hurting me. And a lot of those concerns, can be addressed with good conversations with the community, with our investigators, with our clinicians. And I think you mentioned something, and I'm not sure if this is what you were referring to, but using the local primary care providers,
Mm.
leveraging that trust that's already built. I think a lot of misconception is it even exists among clinicians themselves. Some clinicians might not have a very good idea of what clinical research is, or maybe the phases and what it really entails. And I think part of the work that needs to be done is to get more more hands in the pie, or if we can use the local clinicians to help us to build that trust. I think that's going to be more effective than just researchers trying to engage the patients themselves.
Yeah, that's really interesting because I mean, I think we've seen in some communities that even outside of clinical trials, when say there's a specialist that is, you know, engaged by a family or a population, that they still kind of go back to their primary care provider just to check in. I mean, you can see kind of the levels of trust beginning to build off of that as well, that they found the kind of, at least in the US, that trusted source, if you will, their primary care provider. And then anything that goes beyond that, it's got to be, you know, verified and checked out and whatnot. So Dr. Gallegos, let me come back to you. Jonathan hit on a couple of these things, but when you're looking at a trial, what would you say are the key components of making that would make a trial trustworthy? Is it kind of something you just kind of have to build the rapport, or are there things that operational things that can actually be done to make the trial trustworthy for patients, maybe skeptical patients engaging it for the first time?
I think that's a good question. I think pharmaceutical companies and the people that engage in doing these trials or elaborating the trials, I think have recognized this. And in my understanding is nowadays there are ways in which potentially the voices of patients or their patient representatives can be part of the trial design. Um, Many times, our research trials have been focused on what we call hard outcomes, right? Like somebody, what is the risk of dying? What is the risk of specific complications? And we don't always focus on what we call patient-related outcomes, which are important to our patients and our subjects in the research trials. So, focusing on some of those endpoints, I think, is important to establish that trust between the research trial and the patients that are going to be submitted to that research trial. Also, I think transparency in the trial development, transparency in how these potentially investigational products have come about, like Jonathan mentioned, making sure that the prospective trial participants are well informed about the benefits and risks of the trials and of the investigation products, how they've been elaborated, how they've been tested in healthy subjects and things of that nature. So I do think that more and more we're recognizing that the voice of the patient needs to be heard in order to make sure that that trust is there, so that the patients feel comfortable participating in these trials.
Yeah, Johnson, I'm curious as your perspective on this as well, because Dr. Gallegos mentioned something there about kind of local representation. How important is it to have that sort of trusted messenger, if you will, in the community? I mean, in so many areas, we see that we need, in terms of treatment and outreach, that you've got to have people from that community that kind of know how to speak. I say speak the language, but that's a metaphor as much as anything. We can use that in the mountains of Appalachia as much as in the Bronx or in South Central or in Southwest of the U.S. How important is it to have that sort of reflection of the local community and the importance of kind of the trusted messengers and those relationships?
Yeah, I think it's very important, right? I mentioned the idea of partnering with local clinicians, right? Local primary care providers. And so I think that's one aspect of it, being able to engage as clinical research, engage with those primary care providers, letting them be the ones that carry the message. But also, like you're saying, we're involved in, so to give you some examples, here in Waco, we're involved in local coalitions, right, to address things, health issues in the community that might not be related to our clinical trials necessarily, but it's given us a place to build our rapport, build trust in the community, to be shown alongside of other nonprofit community health organizations. And so when there's issues, we're at the table in those conversations, helping where we can, with our time, with our funds, or whatever it might be. But it's been helpful to be in those spaces, representing clinical research, and really showing them that clinical research could be something else. That's not something that's scary or far away. That it's right here. That it's available. Waco, Texas, isn't a huge city, so like Dr. Gallegos was saying, that one of the things that we're, I think, working on as an industry is trying to decentralize and become more available, and allow clinical trials to be more available. And so I think, most of the time when I encounter someone that has never heard of clinical research, they're surprised to see that how prevalent it is in our small community. And so again, a lot of the conversations are like starting for the first time every time almost. So it's definitely slow work, but it's work that I think in the years of doing this, that's been helpful in building. But it's definitely slow work and important work.
That's so interesting, truly, because Dr. Gallegos, I want to build on that in the next question. When you talk about, Jonathan, when you talk about decentralizing trials or decentralizing kind of outreach, if you will, to me, there's a really close connection between that and having more diversity, if you will, because you're spreading out a little bit more so, and so that potential for diversity comes in. And for whatever wacky reason, diversity has been kind of a tricky thing to talk about these days in this environment. But does diverse enrollment actually improve outcomes in trials, or does it just kind of spread things too thin, if you will? You get too much of a random sample. And so, Dr. Gallegos, I'm curious kind of what your perspective is on that. Does diverse enrollment help with trials, or is it something where you need more of your control group?
Well, I think overall diverse enrollment does help, because at the end of the day, many of these trials, especially these phase 2 or phase 3 trials where these investigational products have already made it through the safety concerns and they have shown some efficacy. At the end of the day, what the pharmaceutical industry wants to do is prove that these products are not only safe, but effective in whatever condition we're treating. And very likely that if they're effective, if you are very stringent in your eligibility criteria, then they might not be able to be effective in other types of population that you haven't included in your trials. So, for example, we know that in many trials, there was issues with representation from women, right? So there were not a lot of women included in the trial. So how do you know that this particular drug is effective not only in men, but is it also effective in women? Is it effective in people in white persons versus people of color? So I think representation does help because it offers the possibility of saying, hey, this particular drug is helpful for this condition across all these different, across gender or across race or ethnicity. Because we also recognize that there are genetic components to many conditions, specifically, for example, in this case, fatty liver disease. We know that some of us, from my standpoint, I'm Hispanic, so I know that my genetic makeup puts me at a higher risk of having complications from fatty liver disease in comparison to somebody from maybe African American person or somebody from Southeast Asia. So I think that representation does come into play, and it's important to try to be as diverse as we can in our recruitment strategies.
Let me follow up with you on one quick question on this. Then you mentioned fatty liver disease, and we know there's not really a lot of awareness of fatty liver disease. Does that lack of awareness impact like patient trust and trial recruitment at all?
Well, I think to a certain degree it does. Maybe not trust, but definitely recruitment. I think for many years, liver steatosis or fatty liver disease has been recognized, but maybe not as well in regards to the potential complications that can stem from unrecognized or untreated fatty liver disease. So even though fatty liver disease is very prevalent around the world, and we basically think that about a third of adults in the United States have some element of steatotic liver disease or fatty liver disease, most people with the condition will not necessarily go on to develop bad outcomes from a liver standpoint. However, I think there's a lack of understanding that fatty liver disease does not only affect the liver, right? It's sort of the liver component of this bigger syndrome, what we call metabolic dysfunction or metabolic syndrome, that is associated with other negative outcomes, such as increased risk of heart attacks, increased risk of strokes, high blood pressure, high cholesterol, increased risk of certain types of cancer, increased risk of issues with sleep apnea and the complications that come from that. So I think for many years we've said, oh, well, patient has a fatty liver, but don't worry about it. You're gonna be okay. And now more and more we're recognizing that no, that shouldn't be the case. We should say, okay, you have fatty liver. This is something that can be serious. So if we treat it early and identify it early, I think there's ways that we can change the natural history of your fatty liver disease. But if we don't, and many a times in my experience, patients come to me when they already have been diagnosed with cirrhosis or complications of cirrhosis or with a liver cancer, even though they knew about the fatty liver disease for decades. So I'm hopeful that for the future, we'll be able to change this narrative that fatty liver disease is not a big deal.
Okay, I'm going to end with two more questions here. And in doing so, I'll beg your indulgence. While I can be a little bit of a nerd when it comes to some of these clinical trial things, I participated on a lot of clinical trial advisory boards and have found an area of interest that I love diving in deep with experts like y'all. So the question I have is about informed consent. It's a really fascinating area of me about what consent looks like, about what it doesn't look like, about how you operationalize that in terms of getting it from patients and whatnot, and understanding the trial. Jonatan, as you know, a community liaison, especially, you're going to be out, talking to people and not just convincing them of trial, but actually getting active consent on this. Can you talk a little bit about what truly informed consent looks like beyond just a form that you fill out that says informed consent?
Yeah, so our industry is highly regulated, right? And so the informed consent process is a very like sacred space, right? Very, um, and so I think maybe what you're referring to, yeah, that it's a continuum, perhaps that it starts with recruitment. It starts with what the patient hears the first time, right? Is it a money sign that's convincing them that money is gonna, be waiting for them on the other side? And it really is just like you're saying. I can see, and so our recruitment is highly regulated as well. And so from the start, from when a patient first hears about us, we really have to be careful, right? We really have to be careful what draws the patient in, and uh, the motivations behind it. And so, but as far as informed consent, once at the site, just like Dr. Gallegos can attest to, it's a very sacred space where we allow the patient to have the consent, be able to read it on their own, be able to, how we do it at our site, we allow the patient to take it home, review it with their family. It is a large document, right? We're talking about, in our trials, on average, it's about 30 pages. And so something that they review on their own, but then even when they come on site, something that they review with our investigators, with our physicians, our APPs, and they're reviewing them section by section, going through questions, explaining it, making sure there's no questions at each point, addressing any concerns. And so it really is a slow process, but to make sure that the patient understands what they're getting into. And one of the big things that we continue to emphasize is that they can leave the study at any point for no reason at all. And those all those things that I mentioned are really based on historical, abuse that's been known in our industry. And so it's really to cover all of those bases, but really to protect the patient. And anytime anything changes, right? Anytime anything changes within the trial, a new informed consent comes up, and we're going through all those changes, making sure the patient understands, making sure the patient understands that they can leave at any time for any reason.
The notion of informed consent or just consent as a sacred space is beautiful. I mean, I feel like that's a poetic way and a very accurate way to be able to get to this. That if we can respect consent, not just in a clinical trial space, but frankly in any space that we involve and consent is required or requested, that it would make things a lot easier and more understood, and would really take huge steps towards engaging this issue of trust that we're talking about. I'm going to end with each of you. Jonathan, you'll get the last word. So we'll start with Dr. Gallegos on this one question. Is there one thing that you kind of wish that every patient knew about clinical research? And obviously the language is loaded there. So this is not just a healthy participant in a clinical trial, but what is the wish that you would have every patient understood about clinical research?
In my view, I think the potential personal benefits of participating in a clinical trial, meaning being able to be exposed to a drug that might be very effective in the future, and that sort of getting early in on the game and being able to access that. And then I think they also, from a societal standpoint, being able to say, well, I was part of this trial to try to make things better, not only for me, but for others that have this particular condition. I think that would be one area of knowledge that I would like to share with the patients. And I think the other one, as Jonathan mentioned, is that these trials, their participation is voluntary, right? So that at any time they can withdraw from the trial. And also they sometimes get improved access to care as trial participants, because typically they get more frequent assessments by the physicians or the investigators. So sometimes that by itself can improve quality of care, can improve quality of life, having more touch points with the investigators.
Jonathan, how about you? What do you see as what's the golden ticket? What's the wish list for you for what you wish a patient knew about clinical research?
I think so. I'm gonna almost say exactly what Dr. Gallegos said. because I think that is our heart. I think the people that are in the right, in clinical research for the right reasons, we really see the benefit. And I think we all wish that patients could understand that and be aware of the benefits of clinical trials, especially when we're talking about late stage clinical trials. There really is, really can be viewed as an extension of care, where, for certain conditions that might not have too many clinical options available and on the standard of care, that research can offer something else that potentially could help more so than maybe other medications that are available. But that also, the other benefits of where the patients are going to have more close care with providers, right? And that they're going to get all sorts of free assessments, free procedures, surgeries. And so there's so many benefits involved. And it can really be a place of, especially, if there's insurance reasons or financial reasons or other obstacles for standard of care, that clinical research can really step into that gap, that equity gap, and really meet some needs.
Yeah, excellent. I mean, as much as we talk about mistrust and about the issues and everything, your point is really well taken that clinical trials, we always at GLI, we talk about, clinical trials are healthcare for the exact same reasons that even if you're in the placebo group, you end up with regular check-ins, somebody to discuss. There's all these other things that are, you're kind of maintaining that with. And I've had several patients, on the positive note, that have ended a clinical trial and are very eager to get into the next one just for that reason as well, especially in this day and age where, the actual availability of medications is still evolving. And so in the meantime, clinical trials are a great place to go. Okay, gentlemen, thank you both for joining us today. I wish I had another half an hour to dig into some other nerdy questions. There's so many things out there beyond informed consent, the role of AI, all sorts of cool stuff that we could dive into, but we'll save it for another day. Thank you again for joining us, and we hope to have you back as guests again soon.
Okay, before we wrap up today's episode, Team GLI is back to help us unpack a few final thoughts. Jeff, thank you for sticking around, and Dr. J. Cox, thanks so much for joining us.
Yeah, absolutely. Always good to do a debrief to break things down after such a great conversation.
Yeah, I agree. There's so much to reflect on, and I'm really happy to be here to be part of this conversation.
Yeah, well, Dr. J. Cox, I think we're especially glad to have you here. I know you've been on Team GLI for the last 7 or so months, but you might be a new face to some of our viewers and listeners. I guess a new voice. Could you share a little bit about what your role is on the team, but also your background with clinical trials?
Sure, absolutely. Yeah, so I came on in January of this year as the director of fatty liver disease program. So my background is pretty vast in clinical research. My most recent position was at a CRO, as it's a phase 1 clinical research site where we did first in human studies. And my role in those positions were as a metabolic and pharmacodynamic specialist, working a lot with diabetes and fatty liver diseases and some obesity work, and also as a global leader in DE&I. So my background, again, vast, public health, as well as late phase clinical research.
I think you're the perfect person to bring in to kind of recap the discussion we had. I wanted to start off asking you a question that's kind of the same thing we were talking about during the episode. What does trust mean to you? And especially in that context of clinical trials and recruitment, especially from your previous experience.
Wow. Yeah. So to me, trust really means believing that the people that we're working with, or as a participant you're working with, has your best interest in heart, that they're following through on what they say they're going to do. They're not going to leave you out in the planning process. In clinical trials, trust, it has to be earned. There's been a lot of medical atrocities, things that have happened in to a lot of these different communities and groups in the past. So that trust really has to be reestablished, and it has to be earned. It's not just about the consent form. It's about transparency, respect, and communication at every step. The participants or patients need to feel like their voices are heard. They want to know that they really, truly do matter. So when that kind of trust is there, participation really means they're coming in as a partner. They don't want to just be a number. They don't want to just be a transaction. They want to really believe that their voices are heard and that their interest is really at the heart of really does matter.
Yeah, let me play off of that a little bit, Lily. What Dr. J says here is absolutely correct. And we heard that from Jonatan a little bit in terms of how it plays out every day in his everyday conversations. And he's really out in the community there in Waco, quite a lot. And so, patients, people, they want to feel safe and respected. And that really starts with kind of the process, how you talk to them, not just kind of what you're saying. This kind of harkens back to the old slogan of nothing for us without us. And the more that patients have partnership in terms of participating in clinical trials, clinical trial recruitment, and then as patient advocates, GLI is really busy in making sure that we have, educated patients as part of everything from development of protocol reviews to, informed consent, which we talked about a little bit in the conversation. It's really, really important that one of the main pathways to establishing trust is simply by being represented and being representatives in the conversation, from the very beginning.
Yeah. I was really struck when Jonatan had mentioned the first step was even beyond recruiting, just kind of being familiar, being a face that people knew, that they were coming around time and time again, to be that presence. And I think those relationships are central to making sure that people of all backgrounds really are able to participate in clinical studies. We really need to treat the full and diverse population affected by any disease. The sample population has to reflect that diversity, right? Or else the data isn't really generalizable. So what does that true representation mean to you both, and how do we get there? In short, that could be a really long answer.
Mm-hmm. And I'm going to jump in here because it really is, it's not just about the numbers again, or the data we're going to collect. It's about access. It's about trust. It's about visibility. We, again, as you even referenced, it's about meeting them where they are. We need to be at those tables. We need to sit there and represent them. Them being the communities that are going to benefit from these medications or these products that are going on the market. We need to make sure that, there's cultural representation, linguistic representation. We need to make sure geographically we're out there. If there's, urban communities, if they're, out in rural communities, we need to make sure that we are intentionally reaching out, doing outreach to these communities so that this representation is at the table. And we know that takes time, but it's very essential that these communities are represented in our trials.
Yeah, I mean, I couldn't agree with that more, frankly. I mean, you want results and trials that actually work in the real world. And so the trials and the recruitment have to look like the real world. I would even take that a little further probably and say they have to be like the real world. I know that there are places where I could walk in the US and internationally where I just simply wouldn't be accepted. It'd be suspicion from the very outstart. But the same people put into positions where I might be accepted. We talked a little bit in the conversation with Dr. Gallegos and Jonatan about Appalachia. And I know that there are places in Appalachia that I can go into. And that's not just simply how an individual looks, which can be important, but also the cultural norms of that, to say this, to not say that. I know that there are parts of, if I'm going to do something in West Virginia, in Appalachia, for instance, I know to call ahead, I know to get permission. There's all these things that other places you may just be able to stroll up to a store or shop or neighborhood gathering of some sort and have the conversation. And so it's all of these norms. And then to have somebody that actually is representative of the populations being able to address some of the concerns, maybe the historical misdeeds that Dr. J mentioned earlier as well, to be able to talk about their own experience in doing this. It just goes miles beyond, just having a generic, rep, clinical trial rep come in and wonder why they're so frustrated that their canned pitch doesn't get any results. Patients know best about patients know best for patients.
Yeah, I think you guys hit on just so many things. And it's not complicated work, but it's very hard work. I think that it really requires taking the time. I want to jump back to something, Dr. Jaycox, that you said, that patients are truly partners in trials and not just participants. What does that look like? It sounds great.
You know what? When you're looking at partners, those are the people that you want to bring to the table early. When you're planning those clinical trials, we want to make sure that they're there when we're doing the study design. We want to make sure that the materials that are produced for the clinical trials represents those communities. One of the things that we said, I spoke to earlier, is being at the table. Again, it's that trusted member. So we need to make sure even your associates, your staff that are recruiting these participants, these partners into these studies, we want to make sure their faces are the people that are going to talk to them, because that goes with trust. We want to make sure because outcomes matters to them. Even again, the materials represent those communities. And it's not just checking the boxes, it's co-creating. So that builds trust. We begin that trust at the beginning of the planning stages. We need to make sure that, again, representation is at that table. We want to make sure that the people that are going to benefit most from these medications or these therapies, whatever these clinical trials involve, we want to make sure that those people are at the table. Those are your partners. Those are the people that we want to make sure those trusted members are at those tables.
Yeah, and I'll add here as well that this takes a little bit of a shift in mindset from what we have traditionally known in clinical trials. The clinical trials approach is, for lack of a better way of saying it, very clinical. And patients tend not to represent that perspective initially. It's not the white coat, antiseptic sort of environment that they live in. And so they want reassurances, they want to be able to trust, they want to be able to ask questions. And the benefit to adapting this new mindset, as we've seen with a couple of clinical trial programs, is that you end up with better recruitment, you end up with better outcomes, you end up with a larger sample size, you just end up with all these things that are higher quality and end up being cost-saving measures as well. The company ends up getting to the end line much quicker and less expensive. You have a higher retention rate within the trials. There's so many ways where this just pays off. It takes a little more effort, and it has, you have to be willing to open oneself up to hearing other opinions, other alternatives, to address any issues that comes about. But it's really important that we step away from this kind of like, we're going to recruit subjects, which is very cause and effect. And instead you have patients as collaborators, patients as partners, patients as having the ability to give input for the process all along. Patients really will make it better for patients.
Mm-hmm.
Yeah, I think that's a great way for us to close off this conversation. And honestly, a call to action that if this sounds like something you would be excited to do, to go to our website and look at A3, which is where we really prepare for that sort of steering and collaboration and input with the clinicians and the research experts. Thanks for listening to everyone. We hope it helps you think differently about research, about trust, and the role that you can play in shaping liver health.
Many thanks to Dr. Gallegos and Jonatan Garcia for joining today. Both of these men are frontline when it comes to engaging communities, speaking with patients, and addressing trust in clinical trials and healthcare on a fundamental level. And thanks to Dr. J, GLI's own Dr. Sharon J. Cox, Director of Fatty Liver Programs, for joining us for the breakdown. Make sure you catch up with the latest activities at globalliver.org and be sure to join the conversation at our socials on Facebook, Instagram, and LinkedIn. You'll see the video version of this on YouTube, and we're also available on the latest podcast platforms, Spotify, Apple Pod, Pandora, or wherever you're listening to this. Have a question, maybe a suggestion, or an idea for a topic for a future episode? Hit us up. We'd love to hear from you at globalliver.org. And be sure to leave a comment, hit those like and subscribe buttons on your platform of choice so you don't miss any of the upcoming episodes and great conversations. It may not seem like much, but this really helps grow awareness, education, and support for liver patients worldwide. I'm Jeff McIntyre on behalf of producer extraordinaire Lily Bainig and the team at Global Liver Institute. We'll see you next time. Thanks, y'all.